to talk to you about awake surgery. Let me start with a case. So this is a case of a lady who came to us, who came to us with a grade 1 subarachnoid hemorrhage, and it's a wide neck aneurysm that went for endovascular coiling. What you see here, can you see my arrow?
Yes.
Okay, so what you see here is a very wide neck aneurysm. They tried to coil this aneurysm, they could not coil it. The aneurysm neck is quite wide. Because she was a ruptured case, it was too dangerous to try to put a stent because of the anticoagulation. So they called me up and said, listen, this aneurysm is, we cannot coil it. And this is a lady, this is the wide neck aneurysm. So this is the situation. The problem is this aneurysm is mostly embedded in the, it's partially cavernous segment and partially subarachnoid. It's all underneath the clinoid. Okay, so let me share with you what the concerns are. Okay, so this is a situation. So this is how we set up this situation here. This is my team. Because this aneurysm, so this patient is sleeping but is not intubated. It's got a veni mask on, face mask. Okay. It's sedated.
Tom, tell us what you see in the EEG.
Because this is part of our study, we do SSEP, EEG, motor evoked potential monitoring for every case.
Okay.
Now, so this is, since it's a very proximal aneurysm, we open the neck, okay, to get proximal control of the internal carotid artery. Now we are, this is the point of drilling the anterior clinoid. For the residents, the anatomy is such that this aneurysm is embedded underneath the anterior clinoid. So the aneurysm neck is all the way from here to here. That's the anterior clinoid there for the residents. So to be able to get to the neck, you have to drill this portion of the anterior clinoid. So this is, just to orient you, this is on the left side, left pterional approach, transylvian, left frontal lobe, left temporal lobe, working through the sylvian fissure. So I'm here drilling the clinoid. The aneurysm is embedded in the bone. It's a very weird situation. You see, that's part of the aneurysm underneath the clinoid right there, okay? This is why we needed proximal control. So here I'm drilling, so that's what's happening. Now we open the distal ring. So this is the distal ring right here. I'm opening that. So the carotid artery is coming this way, the cavernous carotid, and the neck of the aneurysm is going to be here. That's the optic nerve. That's the subarachnoid carotid artery there. Sorry, I have not edited this video, but okay. So now we're opening, so the carotid artery is right like there. Now we have to open the proximal ring. So that's the aneurysm right there. Optic nerve is there. The subarachnoid carotid artery is here. So the carotid artery is going this way. That's the aneurysm dome, okay? So I'm opening both rings. That's the aneurysm, okay? So that's a carotid artery in the subarachnoid space right here. Left optic nerve. I've drilled the clinoid here. This is the dome of the aneurysm, and the neck goes all the way proximally here, okay? So this is a concern. I don't like to use retractors if we can avoid them. So in general, I do not use retractors. Okay, so that's an internal carotid artery right here. Okay. Now, this is a situation we have. Left optic nerve, carotid artery, need more access. I don't have access to the proximal neck of the aneurysm. So this is the aneurysm here. I'm drilling in front of it now, okay? So those of you who like anatomy, this would be very close to the sphenoid sinus here, just so you know. So that's, anyway, so that's the optic nerve, aneurysm. In front of the aneurysm, I've got a drill. So we are in this portion of the internal carotid artery, okay? In front of the aneurysm, right there. This is a portion of the carotid I call the sphenoidal carotid. Okay. Now we need to control proximal control. So this is an important step. This is why the awake makes a difference. So I'm gonna we're occluding the carotid in the neck.
We have the carotid is occluded on the left side.
Carotid is occluded on the left side.
Then you squeeze my hand again. Good. Let go. Perfect.
Okay, so we're occluded. Let me have the bipolar now. Down to 20.
See, the whole issue is this. When you occlude a carotid in a patient under general anesthesia, you have no idea. The patient may tolerate it just fine, but some patients don't. And neurophysiological testing is variable. There are false positives and false negatives. Now I'm 100% comfortable. While the carotid is occluded, the patient is talking to me. She's doing fine, meaning I have very good collateral flow. I'm comfortable. I'm not nervous. Now I do my regular thing where I bipolar coagulate the aneurysm. Okay. So I am coagulating the aneurysm here.
Perfect.
The patient is doing great. I have no worries. I have no worries, right? So I am doing my thing. I'm relaxed because I'm not nervous. The carotid occluded. Now I have to open more because this neck is really proximal. So I'm going to open this part of the wall of the dural ring right there. So the carotid cavernous sinus, sphenoidal right here, going like this, okay? So I have to open more. Now we're ready for clip placement. Now I'm placing a clip. Of course, this tip of the clip now is in the cavernous sinus. You'll see some cavernous bleeding here.
Squeeze my hand again.
As I'm closing the clip, I'm checking everything.
Perfect.
I make sure I get the whole neck since we did so much work.
Squeeze my hand one more time. Squeeze tight, tight. Good. Let go. Perfect.
16, your aneurysm is taken care of. It's all cured, okay? Now you get to sleep while we do the closure.
All right.
Great.
So I'm telling the patient, you did great. The aneurysm is taken care of. Now we're going to put you back to sleep to do the closure. So the elements that are critical in this case we just discussed, we know right away. So we can reverse the step. If there's a problem, we can take the temporary clip off. If there's a problem with the perforator, we can readjust. That is the advantage. Okay. Second question you may ask me, okay, you talked to me about aneurysms. Now tell me, what is the benefit of awake surgery for AVMs? Okay, that's a good question. So I'm going to show you a case. This is a motor strip AVM in a international patient that was sent to us. She's a university student. Okay, she has this AVM here. Okay, right smack in the motor strip. She, let me show you, she was sent to France for embolization, and they looked at this case in Paris, and they decided that they could not embolize this. It's of course, what's important to see here is two very important things. One, this AVM is getting supply from the MCA, but also what you will see, it's getting supply from deeper down, okay, coming through the posterior choroidal, medial choroidals. Okay, so let me explain this. So that's the AVM right there, right in front of the precentral, in front of the central sulcus. Two concerns for the residents in this kind of surgery that is very important to understand. First of all, to operate in somebody like this, young patient, motor strip AVM, it's not an easy decision, okay? The reason why she was sent to me because she had bled already, and she's very young. If she had not bled, I think you would have a hard time convincing yourself to try to operate on this young patient with a motor AVM, okay? So what are the concerns in doing this kind of surgery? There are three concerns. Number one, we're in the motor area, so the cortical motor area is a concern. What's number two? Number two, you have these cortical branches. There are some normal supplying the motor area and some are supplying the AVM. How do you know for sure? That's going to be very important. Number three, you have this deep supply coming through the internal capsule. So that is a challenge in doing a surgery like this, okay? You see how the deep supply coming from the ventricle, from the choroidal vessels, okay? That is to me, in AVM surgery, in general, awake or not awake, it doesn't matter. This sign, I have found in my experience, this sign is the most dangerous sign there is, okay? I don't care how big the AVM is. If it's getting only cortical blood flow, that is a lower risk operation. When the AVM is getting supply from deep, from choroidals or lenticular striates, no matter how small it is, that is a dangerous sign. That's something I have observed in my career and my series of AVMs, okay? Just so you know. Anyway, so that's the situation. So how are we gonna handle this situation? Okay, how am I gonna know 100% for sure in surgery? This is showing you the functional and showing you the tracts, showing you the AVM is just next to the, next to the internal capsule, which is, of course, is a concern in this case, okay? So what is the situation we got in our hands and how we're gonna make this safe? This is a functional MRI showing you the AVM nidus is right in the motor strip itself, okay? Fine, all right, so not an easy decision, but this is a central sulcus here, okay? The AVM is embedded inside the central sulcus, all right? So this is, I like to use very sharp dissection. I do not like blunt dissection. It is almost the opposite. The sharp dissection is safer than blunt dissection. You see, everything I use is sharp, okay? Because you have a lot more control than blunt dissection. We could discuss that another day, but I'm just trying to discuss with you technique issues as we're doing it, okay? Sharp, sharp, sharp dissection. A lot of control versus pulling and you don't know what you're gonna tear, all right? So that's counterintuitive, but it is actually the truth, okay? And that's, so this is the main draining vein that's coming to the surface, okay? That's the large vein coming to the surface. I'm just gonna dissect this area a little bit. Let's get to the critical portions of this surgery that's gonna make a difference in the outcome, okay? Why the way I'm doing it is gonna help us with the outcome. Okay, so there's one branch right next to the motor strip. I'm not 100% sure, I'll be honest with you. Is this only an AVM feeding vessel, or is this a normal bystander vessel feeding the motor strip? Under general anesthesia, there's no way of knowing, okay? We have a translator in the room, okay, because this patient is from overseas. He's telling her to squeeze her fingers. What? I put a temporary clip on. Now for the residents, this is 100% test. An AVM feeding vessel, a pure feeder, does not supply normal brain. So if you occlude a pure feeder, it should not affect function at all. If you occlude a vessel supplying the motor area, within seconds, you will have effect on function. So you know 100%, it's not a guessing game. So as I put the temporary clip, she's able to 100% squeeze and do fine.
Okay.
Okay, I'm happy, I coagulated now. If I was under general anesthesia, I would be very nervous. I would not know. I would be guessing. Okay, so I'm now deep inside the central sulcus. Okay, inside. This is a critical issue. You saw how I showed you those deep feeders coming from the ventricle, the choroidal feeders coming in. Okay, I am putting temporary clips on these, the ones I think that are feeding the AVM, not the ones hopefully that are feeding the internal capsule. I test each one of them before I coagulate. You see, that's what I'm doing right here. So I know 100%. You see, that's a deep feeder right there. You see, because it's internal capsule, we're checking the leg. You see, so I am knowing 100%. Now this is. I'm checking as I'm closing that vein. She's cooperating very well. You see, it's the comfort I have in doing a case like this because I know 100% every step of the way what outcome issues I'm dealing with. Okay, so that's an issue. Okay, that's an issue, and of course here I'm including the last vein, the last draining vein right here. As I cut the last vein, I'm happy. Okay, we've gotten the whole AVM inside the central sulcus. Okay, you know, so it's that's the whole AVM is gone. ICG. Okay, that's her. Post-op day 7 in clinic to take her staples out. A year later, I was a visiting professor in the Gulf area of Dubai, and she and her father and little brother came and see me. She finished her university. Okay. So this is my series. A group is putting together my series of AVMs. Okay. So if you look at the outcomes in the biggest series of AVMs in the last 20 years, where people who have done over 100 AVMs microsurgically, our outcomes have improved with time. You see how we really have decreased the morbidity quite a bit and the mortality. Compare myself to myself. As I advance the technique I just showed you, compared to when I did the standard Yashigil technique. We went from morbidity 6.6% to 4.9%, mortality 1% to 0.5%. That is showing one surgeon comparing his results to his own results. So there is no confusion. Then you ask me, okay, what's the benefit of doing bypass surgery awake? Okay. You told me about aneurysms. Okay. You told me about AVMs. All right. Now tell me, why do a bypass surgery awake? So I'm going to show you a technique that I like to use, which is a maxillary artery to MCA bypass. This is from Bob Spessler's book that they named it for me. I'm very honored about that, but I'm going to show you. This is the AMAX technique. I'm going to show you how this is done. So this is a maxillary artery right here. Okay, it's a large artery that I like to use. Instead of going all the way to the neck, we could do it right here. See, I use a maxillary artery right here. Okay, that's a maxillary artery. All right, I described this technique a few years ago. Okay, and now it's being used by a number of vascular neurosurgeons. How do you harvest a radial artery in a patient who is not under general anesthesia? Well, we do a radial artery block, an upper extremity block, okay? So I have my colleague, a neurosurgeon, doing the harvest of the radial artery. Yes. My chief resident is doing the neck, and my my fellow is doing the cranial artery. Make sure there are no big holes. It's a radial artery. At the same time, it decreases the. Okay, so as you know, first we attach the the radial artery to the maxillary artery extradurally in the middle fossa below the dura. Of course, this is not a risky step because the maxillary artery is used by ENT, they occlude it, it doesn't supply the brain, it doesn't matter. So I'm attaching the radial artery to the maxillary artery here. That's not a big deal, okay? Now we check flow. You see, that's a flow coming radial artery through the maxillary artery. It's a great vessel. Okay, next are the two steps that are the most dangerous, high-risk steps in high-flow bypass. What are these two steps, and how do we avoid complications during these two steps? Step number one, we're going to attach the maxillary artery to the middle cerebral artery. Okay? When we attach it to the middle cerebral artery division, we have to temporarily occlude the middle cerebral artery division. Under general anesthesia, how do you know the patient is tolerating that length of time while you're doing an anastomosis? You don't. You're guessing. How am I going to know here? Let me show you. So I come to the sylvian fissure. I put a temporary clip. I wait. Check the patient.
There, squeeze my hand. Perfect. Let go.
Okay. Now I'm happy to proceed to do the anastomosis because I'm talking to the patient and the patient is moving her left hand. I've had situations where the patient, you put a temporary clip, within 30 seconds, the patient cannot tolerate it. I stop. I go to another division until I find the right division where I can do the anastomosis. This step, you cannot know this under general anesthesia. You usually pick one vessel and you go with it and you pray, okay? This is the advantage. See what I'm doing? I'm doing my anastomosis and the patient is fine. Doing fine means it has very good collateral flow, okay? I'm happy, all right? You see, I do my IMAX to MCA bypass, very nice, I'm happy. Now, what is the second dangerous step? After you do the bypass, you're gonna permanently occlude the internal carotid artery on this patient. Many of these patients have failed balloon occlusion tests before surgery. So you are permanently closing off the internal carotid artery. How do you know for sure that your graft is good enough? It has no problem in it. It's bringing enough blood flow to the brain to replace the parent carotid artery. Under general anesthesia, you don't know. You occlude the carotid and you hope for the best. Here, how are we gonna know? I'm temporarily occluding the internal carotid artery. Now, I'm gonna do a 10-minute test of occlusion test. You see, for 10 minutes.
Deborah, squeeze my hand again. Deborah, squeeze my hand real tight. All right, there you go. Let go. Perfect.
10 minutes.
Look at your toes, Deborah. Look at your toes.
Great.
Good job.
You see, that is the 100% test. I know my graft is working for 10 minutes. I mean, you really would know within 1 minute, but I do for 10 minutes just to be sure. Now 100% I know my graft is working and I can close the carotid artery. Now I permanently occlude the carotid artery. Okay. I like to use silk suture. You could use whatever you want. Some people like clips, whatever. Okay. So this is the end result. The carotid artery is occluded. The bypass from here to here. The giant aneurysm is gone. Okay. You know, instead of a graft all the way from here to there, I think this is better. Okay. Anyway, so that is the advantage of doing this awake. So I'm going to explain to you how we did this awake work over the last few years. This was under IRB protocol. The consent for the patient required multiple steps. Consent by the surgeon, outpatient clinic, or in the hospital. Consent by the surgeon on the day of surgery. Consent by the anesthesiologist. Consent by the resident. So it's a very detailed procedure to explain to the patient this option. So this is my data from 2013 to 2019. This was done for complex aneurysms and vascular malformations, okay? And not for, so it was under very defined definition. Large aneurysms, aneurysms needing bypass, and AVMs, grade 3 and above, okay? Contraindications, patient declines option, Anesthesiologist deems the airway anatomy not suitable for awake procedure. And of course, any cognitive issues in the patient is an automatic contraindication, okay? So this was done from 2013 to 2019. Total of 202 surgeries on complex aneurysms and AVMs I did. Out of the 202, 162 or 80% were done awake. The other 20% declined the option. This data was gathered by a board of physicians, not from Department of Neurosurgery, 9 physicians in an independent board. This is them collecting the data from the electronic health record, completely every detailed data about every single patient, okay? And you see here, all this stuff, of course, is personal information of the patient redacted. What you see here is morbidity and mortality. And you could see top of anesthesia, conscious, all these are conscious sedation, meaning not general anesthesia, okay? So this, what's nice about this review, that it is not, like typically we do our own reviews in our department, we, the surgeons, and you know, we can be biased. What's nice about this, because this was a major study, is done independent review by an independent board, okay? So this is the data right here, and I'll show you that in more detail in a minute. These were 30 patients who declined the awake surgery for complex aneurysms and bypass, and I'm going to show you the outcome. So when you look at these cases, this is awake, this is general anesthesia. Morbidity, same surgeon, same team, same kind of cases. Only the difference is these patients refused awake surgery. Morbidity, 10% went to 4.3%. Mortality, 2.5% to 1.8%. And this is combined. Of course, as you know, these are high-risk lesions because these are large aneurysms needing bypass or complex AVMs, okay? So you see, we essentially halved the morbidity and mortality. So, and it's direct comparison, the same surgeon, same team. It's not like we're comparing apples and oranges. So of course, this is the largest series in neurosurgery with awake surgery for aneurysms and AVMs. This data just came out recently, so all this data will be out. So this is important, I think, to understand in my own growth and development that this technique really has had an impact. And I'm talking to you as someone who's done hundreds of aneurysms and hundreds of AVMs under general anesthesia before I did this. So I'm talking to you from experience, having done it under general anesthesia. Okay, so I do believe it made a significant difference, and this data shows it, okay? The final point I want to make is a philosophical point, okay, which is my next phase of my career. I'm really trying to affect the life of neurosurgeons in their future careers. And we need the senior neurosurgeons in this symposium here in your department to really help out with what I'm going to say here. So this is a Nobel Prize winning work from year 2000, which looks at your confidence in your years and experience. So let's say when I finished neurosurgery residency, like Felipe right now, finishing residency, he thinks he knows everything. He's a master of everything, okay? I thought the same when I finished my residency. I thought I knew everything, I'm master of everything. Completely false. What happens to the person when they go in their career? They start having problems, start having complications. Their confidence at some point gets very low. Then as you get more experience, as you get more specialized, as you have your long series, you get to a point that you become an expert or a master, okay? Just like the professors here in your department right now, whom I just met, okay? The problem is this here can take up to 30 years in a neurosurgeon's life. What the problem for me in that situation is, we lose some of your prime years of your life where your outcomes may not be as good as when you are at your best. Plus, you are not able to contribute to research as well as you can here. So my next phase of my career, what I'm doing is I want to move this curve to the left. Meaning we can achieve this point much earlier if we make a number of changes in education and in training. And I know what those changes are. So I want the professors to help us. So we, in the month of July, we're making a global announcement. I'm establishing this University of Neurosurgery that is going to address this. It has a track for neurosurgeons. It has a track for residents and tracks for medical students who want to go into neurosurgery. 3 different tracks to really affect the careers of people in the field of neurosurgery. Okay, so I hope the professors here in Medellin in your department will be part of the team to help us accomplish this in the global stage. So, so it's been my pleasure to really speak with you here and to share with you some of my own experience with some of these lesions. And I'm happy to answer any questions that you have.
Doctor, first of all, congratulations, because this is very interesting and also difficult. It is frightening in the first video where you have the drill over the bell of the aneurysm. I think that's very difficult, especially if the patient is awake, and a little movement of the patient is very, very, very complicated. I have a question to you, is that if you occlude the artery and you don't have any deficit, have you had patients that have problems when they are awake after finishing the surgery?
That's a very good question, Professor. One of the biggest lessons we learned in this experience is the answer to these vexing questions that we have known a long time. And all this stuff is going to be published. We have now figured out things that we had not known because we had not had data on awake patients before. What we found out so the data that exists in the literature says you can occlude the carotid artery for 10 minutes, the MCA for 5 minutes temporary. All this is really it just does not apply. Every patient is different. Even within the same patient, the anatomy is very variable. So what we found out, that if there is an issue with flow, you will know within the first 60 seconds. If there is not a problem right away, it's very unlikely you're going to have a problem later. Now, if you have a problem later, it's not a flow issue. It's embolic problem, something else. So if actually 10 minutes is very long, but I want to be on the safe side. In the patients, when we put a temporary clip on a vessel, carotid, basilar, vertebral, the patients who are going to have a flow issue, you will know within seconds. If they're not going to have an issue, we have left that temporary clip on for 10, 15 minutes, no issue whatsoever. So the problem, what we're finding out through our work, is that if there is a flow issue, you know right away. It's not a delayed issue. You have a delayed problem that is unrelated to flow. That's an embolic or a thrombus or something like that. So that is why this work has been really pivotal in our understanding of the blood flow situation in temporary clipping. So thank you for that question, Professor.
But I also have another question. When you have the patient at surgery, you have it in an optimal condition, but when he is in the room, the blood pressure can be lower, and I understand what you explained, but you don't have problem with the flow of the blood in that circumstances?
Yeah, so we do a hypotensive challenge. So when we every time we do temporary occlusion of the carotid, we do a hypotensive challenge, part of the protocol. So we drop the pressure. We drop the pressure, and we check. So that's part of the protocol actually for carotid occlusion. So we really bring the pressure down. We're using drugs, bring the pressure down, and we test the patient. So yes, these are very good questions, Professor. That's what we're doing in this case. So that's been really, and if you compare my results of high flow bypass under general anesthesia, my results with these techniques under awake, there's a significant difference in outcome.
Okay, thank you very much. I don't have any more questions, and I would like if somebody has to add something to the professor.
Nacho, yo
Doctor.
tengo una pregunta. Professor, good morning. I have a question. What happens if the aneurysm get ruptured in the middle of the procedure?
Yeah.
What happens with the brain? Because I think that the worst scenario is a brain edema with the wake patient.
Right. So this is a question I get asked a lot, and I think it's a very important question to ask. If an aneurysm ruptures while you're doing surgery, the outcome is going to be, in most cases, can be bad, whether the patient has the general anesthesia or not. Okay. If you're going to have a situation where you're going to have brain edema, the brain is coming to you, there is, that situation you just described is a very poor outcome situation. I mean, if you have a situation where the brain is edema and herniating out, that's going to be a bad outcome situation. I don't care, general anesthesia or not. Okay, so I think it's very important to really take that group of patients to understand that's a poor outcome patient, no matter what happens. Okay. Secondly, every patient that we do awake surgery on, we have a specific protocol how the patient and the neck is positioned, so the anesthesiologist can intubate very easily without us taking the patient out of the pins. Of the patients that we have done now, over 200 awake surgeries, we have not had to intubate a single time, okay, during surgery. Based on the review that was done by the independent board. But since you asked a question, I want to show you this exact situation, so that I can show you what we do in these situations and how we handle them. The key issue is that we need to stay, if an aneurysm ruptures, as far as I'm concerned, nothing changes. You do what you do if the patient was under general anesthesia. It should not make a difference from that standpoint. So let me just pull something here. It may take a minute for this to load, but I'm going to let that load for a second. But please continue with your questions for me, Dr. Francesco.
I don't have any more question. I want to see what do you do in these cases.
Okay, I will show you right now. Thank you.
¿Alguien más tiene preguntas?
Doctor Zorro, adelante.
Good morning, Professor.
Good morning.
Very good conference. I have question. What is your opinion about MRI functional tractography for AVM and area eloquent?
To me, I use it all the time for all AVMs. The question is always, are we overusing this technology? But I think it helps me in the planning in a big way, tractography. It really affects the planning of the surgery, especially in eloquent areas. I think it makes a big difference. So I think that that is something that I use very commonly for all AVMs.
Yeah. Second question: if you have no compromise area eloquent, is necessary surgery awake the patient, AVM?
If the question is if you don't have eloquent area AVM, is that what you're saying?
Yes. Yes.
No. First of all, let me say this. What I showed you is not. I'm not saying this is standard of care. So I'm not saying it's necessary for any patient. Okay. What I'm saying, in my hands, after a lot of experience, the outcomes are better. But we are not saying this is how all surgeries, eloquent or not, should be done. I have never said that, just so you know, okay? Because we have to be careful. The reason why I can do this, because you see, if I started some years ago when I was started doing aneurysms and AVMs, I would not have been able to do this awake. It takes a lot of experience to get to that point in handling these situations. So this should only be done in the hands of people who have a lot of experience doing standard surgery under a general anesthesia. So this cannot be a recommendation. This cannot be, I'm not saying that this is a standard, what I just showed you, okay? I'm just showing you what I'm pushing the limit to improve outcomes of patients, all right? And this technique I just showed you, I could not have done this when I was developing my series, because I was so nervous just operating on the AVM or the aneurysm, let alone the patient being awake and talking to me, okay? So it takes a lot of, you have to get to a certain level. And secondly, it's a reverse phenomena. Now I am very uncomfortable if the patient is under general anesthesia. I'm much more comfortable now because I know the patient is doing okay. If the patient is under general anesthesia now, I'm very uncomfortable because I don't know what's going on. But it's a development. It takes time, to do that. So let me go back to the question that Dr. Louise asked. I'm gonna share screen again. And then I'll come back to answering more questions.
So all your surgeries are with the patient awake?
All my surgeries except if the patient declines the option and
Yes.
the physiologist says, no, the airway is an issue, if we have to intubate, or the patient has decreased level of consciousness or cognitive issues. 3, no way. Every case, for me personally, I prefer the awake, but in the situations where the patient declines, I will do it under control. So let me show you the situation that Dr. Francesco asked. Okay, that's not the ruptured case. Let me find that case here. Second. Hang with me 1 second, please.
Doctor, and the time you take to surgery is the same?
Actually, is a little bit, at least over time, I found it to be a little bit shorter because everybody with the awake patient, but maybe because my experience is getting better, maybe that's why it's shorter. I don't know for sure. The one thing I know for sure, it is the length of stay of the patient is much shorter. Is much shorter for sure, the length of stay, okay? Because without general anesthesia, really, it's the patient goes to the ICU for 1 night, next day on the regular room, because, if you have, general anesthesia really adds a lot of, length of stay for sure, from that standpoint. Give me 1 second, let this load, but I am open to more questions, please. One second here. I just want to pull this case.
No problem.
They reconfigured my computer last night, so unfortunately all these things are in the iCloud. Are you okay with time? If you give me just 3-4 more minutes, please.
No problem. It's your time, Professor.
Yeah, thank you. See, the question is that when I present this around the world, it's a really good philosophical question here. And I know we have some tumor surgeons in this board here. For years, neurosurgery, we have been doing awake surgery for gliomas and for functional, okay? And people are okay with this. For gliomas, you have diffuse area of the brain and, you know, maybe it can help with the awake. For vascular, I believe it helps a lot more because you know 100% with everything that you're doing, okay? So I believe that awake makes more sense for vascular than it is with tumor surgery for gliomas because you know precisely every function with every vessel. So I find it sometimes ironic around the world that people are okay if it's done for tumor, but they have a question when we do it for vascular. So that's the ironic question that I am left with this issue that I find intriguing from that perspective. Do the professors here have anything to add to what I just said about comparing the awake tumor surgery to the awake vascular?
Dr. Salim,
Yes, Professor.
I would like to know if you have considered the endovascular treatment for the aneurysm you have operated on, and that's a long surgery, long time. The endovascular treatment, you know, is shorter. And why do you offer that complicated source?
Yes. No, Professor, that's a good question. All our patients, the first option is the endovascular option for these complex cases. The cases I showed you, the ruptured aneurysm, the wide neck, they tried to do endovascularly, they could not. And you cannot put a stent in ruptured case because they have to anticoagulate. And in a ruptured case, if you put a anticoagulate the patient, there is a very high risk of massive hemorrhage. So yes, the cases I'm showing you are really cases that endovascular people have tried or have had the option in first. So 60% to 70% of the cases in my institution undergo endovascular treatment. Okay, so I'm showing you some cases where that option does not work for some reason or another, anatomy or something else. No, I agree with you. I mean, you know, we're not going to do the surgeries for cases where you could do safely endovascular treatment. I agree with you totally. Okay. So this is a good example. The case I'm showing you that Francisco asked me, this was a case of a patient who actually ACOM aneurysm, grade 1 hemorrhage. They tried to coil this aneurysm, but again, endovascularly, the neck was very wide. They could not have the coil stay in the aneurysm. And again, you cannot put a stent in the aneurysm in a ruptured case. It was sent to me for surgery. So that's Professor Luis Carlos. That's the reason why we're doing that. So this is a case where I'm going to explain. This is the aneurysm right here, wide neck. They tried to coil it. They couldn't. This is a case where Dr. Francisco asked, what do you do when the aneurysm ruptures? In this case, I had the weirdest situation where the aneurysm ruptured as we're opening the dura. I wasn't even down to the aneurysm. It was a very unusual situation. So this is, the patient is awake. I very quickly get down to the Sylvian fissure. This is a temporary clip here, okay? So this is, Dr. Francisco asked a question. Patient is awake. What do you do if the aneurysm ruptures? You see, I'm handling it right there. That's the aneurysm right there. You see, that's a hole in the aneurysm right there. You see, the patient is awake. You see, the patient right there is awake. We're calm and quiet. So the question Dr. Francisco is asked, what do you do? Well, I'm doing exactly what I would do if I was under general anesthesia, nothing different, right? You see, I control the whole of the aneurysm right there. Right there, that's the aneurysm right there, okay? That's a ruptured, intraoperative rupture of an aneurysm, okay? Right there. That's A2, A2. Now clipping the aneurysm, that's A2. Okay, so that's a situation that I was asked about. What do you do with the aneurysm ruptures? The answer is do exactly the same thing that I would do if the patient was under general anesthesia. No different whatsoever. And if the patient needs to be intubated, we have a system by which our anesthesiologist can intubate while the patient in that position. Before surgery, we have designed the whole thing. We have looked at it. We have done everything before we place a patient, okay? But so far, knock on wood, we have not had to intubate a single patient in this study, okay? So the answer, exactly the same thing. So I really go back to the question, why is it okay to do awake surgery for gliomas and functional, and not okay or vascular when I show clear-cut benefit to vascular far more than even for tumors? That's a critical question that I am posing in a philosophical way, of course. Not in a, you know, not in a direct way, but in a philosophical way. Why? Because with temporary clipping, you know right away, in second. With gliomas, it's diffuse brain, you don't know, maybe, maybe not, awake, maybe, maybe not. You know, it's a lot of guessing game. With vasculars, 100% you know right away. So the philosophical question is, why is it okay to do awake surgery for gliomas and for functional, and not okay to do it for AVMs, for example, which is very similar you know, you have vessels, you're in the cortical surface. So that's really the question that I pose. I want people to really think about that, okay? I want people to really think about because we have shown that the benefit in this outweigh the benefit of awake glioma surgery, outweigh awake functional from the benefit of the awake testing. So that's the question that I think that needs to be posed to really address this issue. I fully recognize, and I'm not making this a standard of care or a recommendation, because I believe because vascular is technically so much more challenging than glioma surgery, that you have to have had hundreds of aneurysms, hundreds of AVMs under your belt before I would recommend a surgeon to get into the awake surgery, because I would not have been able to do this in my growth phase in my vascular work, because it requires a totally different mindset, right? But from a larger perspective, because the outcome difference, that's a question I'm posing.
Okay, doctor, I have a final question. I understand exactly what you say, but my question is, if you have another aid, for example, evoked potentials for surgery. I know what you say, that you can see the deficit immediately, but it's interesting to know if you use another aid.
Yes, I do. So this is what made this study very interesting for us. The issue is we had a subset of patients in which the patient developed a deficit from a temporary clipping, but no change in SSEP, no change in motor evoked potential. A small subset of patients. I'm going to show you right away, okay? I need to show you this because this is very important, from that perspective. Because that's the issue that I am trying to address, is the issue, what's the difference between this testing and knowing from physiological testing, okay? Okay, so this is from my early cases. I'm going to show you, this is a simple MCA aneurysm, wide neck again, and akin to Professor Carlos, this case is not a case that should undergo endovascular treatment in a young patient. Wide neck, middle cerebral artery aneurysm. Today, in the best centers, the right treatment is clipping of this aneurysm, not endovascular treatment. This is different from a basilar tip aneurysm. This is the best treatment for this aneurysm today, with the best technology of endovascular available, is microsurgical clipping in the middle cerebral artery territory. Okay. So let me show you. So again, same situation. You see, we're doing SSEP EEG monitoring. So this is the aneurysm right here in the sylvian fissure. I think this answers, Professor, your question you just asked me. What is the issue of evoked potential? In this case, we're doing both evoked potentials and awake testing. Okay, so I'm inside the sylvian fissure. Okay, and you will see here. Unfortunately, I can't get behind this thing. All right, so we'll just watch it. Essentially, so grade 1 background hemorrhage, and I just said to the residents as well, the right treatment for this middle cerebral artery aneurysm is microsurgical clipping, not endovascular coiling in this specific case. Okay, so this is the neck of the aneurysm. The neck is wider than the aneurysm itself. This is M2, another M2, and then we're going to see the M1. And this case is going to answer the question the professor just asked, okay? And that's the critical question that we're going to address here. Again, I don't like to use, retractors and stuff, but that's fine. You can use what you feel comfortable with. Again, I like sharp dissection. Okay, you see what I'm doing here? You see right there? Okay, this is in real time.
Excellent.
I put temporary clip on the M1. The guy is squeezing his hands. So I shrink the aneurysm to get the good neck right there. Okay, this is in real time. Watch what happens in 30 seconds. I told you everything happens within 60 seconds. Okay, so within 30 seconds, right now, you will see the guy in 30 seconds, as I told you before, he cannot move. He said, I cannot move my hand. Okay, EEG, SACP, completely normal. Motor evoked potential, 100% normal. Okay.
Fingers, Terry? He's not moving his fingers.
Okay, I immediately say, give me temporary clip remover. I remove the temporary clip. He is starting to squeeze his hand right away within a second. Okay,
Right here.
you see right away.
Excellent.
Nothing changed. EEG, SACP, motor evoked potential. These false positives and false negatives is where when we have surgery, everything goes fine and the patient wakes up with a deficit. How do you explain that? That's the issue I'm trying to get to in this specific thing. Okay. Now I'm clipping it without the temporary clip because I know this patient is not going to tolerate occlusion of the M1. Under general anesthesia, I would have never known that this patient does not tolerate M1 occlusion at all. I would have left a temporary clip on, and potentially this patient would have woke up with a stroke. That's the issue that I'm really trying to get to in this question you just asked me about this. So that's really the issue that these are the cases that built up over time for me to understand much deeper way the concerns that we have when the monitoring fails for false positive, false negative, and you're admitting in the middle of surgery, how do you know for sure? Those are the things I'm trying to address with this work. So I think, again, this is not a recommendation. It's not a standard of care. I think this is something neurosurgeons have to think about for a long time, decide what's best for them, for their patients. I'm merely just sharing my experience and my observations. I want to be very clear about that. I'm just sharing my observations, okay? I have not written anywhere in my publications. I said, this is how it should be done. This is the way to do it, only way. I have never said that anywhere in the world. I'm merely sharing my personal observations and my outcomes.
Okay, doctor. Thank you very much. I really don't have any more questions, and congratulations again.
Thank you. Professor Luis Carlos.
He made the question first.
Okay. Oh no, he's okay here. Yeah.
Yes.
Thank you very much for your conference. With all reasonable reasons, you have nominated one of the best neurosurgeons. And we have no doubt this has been one of the most interesting conferences. So we are pleased to hear your speech in your conference. Thank you very much.
Thank you, Professor Luis Carlos Codavid. Thank you, Professor Ignacio Alberto. It's an honor to meet you. I hope to meet you in person. I hope to meet all of you in person and visit your beautiful country.
We hope this is not the unique time. We hope to have you again.
Thank you so much. It's
okay.
my honor. Thank you. Thank you.
Goodbye.
Thank you. Bye-bye.
Thank you.
Bye-bye.
Doctor Felipe Gutiérrez, muchas gracias por acompañarnos y por invitar a este maravilloso conferencista.
¿Cuándo empezaremos la...
Cantaremos entusiastas a nuestra universidad, alma mater de la raza, invicta en su fe.